Good morning, everyone. I'm Dr. Bouarroudj Noreddine, anesthesiologist at Clinique Maissalyne, Constantine, Algeria. I'm a specialist in anesthesiology, intensive care medicine, interventional pain management, and ultrasound-guided regional anesthesia. Today, I'm very excited to welcome our special guest speaker from Abu Dhabi, Cleveland Clinique. Dr. Salti is a practicing consultant in anesthesia and pain medicine. He also obtained the European Diploma of Regional Anesthesia and Pain Medicine organized by ISRA. Dr. Salti has a great passion for educational activities reflected in his active participation, presentations, workshops, and publications in major textbooks, as well as journal articles and interventions in national and international events. He received many professional and academic awards. He is the chairman of NISORA and co-founder of the Gulf Pain School. So today, he will be sharing with us his expert opinion on preventing pain chronification and the role of regional anesthesia. In fact, if regional anesthesia remains one of the most important tools in multimodal analgesic toolbox, blocking injury-induced activation and sensitization of both peripheral and central nervous system. Regional anesthesia may reduce the risk of chronic pain after surgery, a frequent and debilitating condition. Let's get started. Dr. Salti.
Can you hear me?
Yes.
Perfect. So, can we start, Natalie? Okay, perfect. Thank you very much for the kind words, and I'm very glad to be here in this platform. And as a start, I would like to, as a Palestinian, I would like to thank the WAFSA for all the efforts to help our friends in Palestine. And thank you, Patrick. Thank you, Patricia, for your kind words for our colleagues and brothers in Gaza, West Bank. It's a hard situation, but we have to comply, and God bless. So as you can see in my first slide, I work in Abu Dhabi, Cleveland Clinique, Abu Dhabi. I did my training in this nice university, René Descartes University, Paris 5 in Paris. And René Descartes is a philosopher and physician who in 17th century described the pain pathways. So we're going to go through a story of the pain pathways, showing how we can prevent chronic pain through regional anesthesia practice. I have no disclosure. I just am founder of Gulf Pain School and current president of the Gulf Pain Society. So as I said, René Descartes described in 1664, mentioning that pain pathways is like an on and off switch. And at that time it was something interesting, but of course we know that this is not right, and we'll see at the end of the lecture how these pain pathways are evolving. So pain after surgery and chronification of pain is something very interesting. This transition between the acute, whatever, nociceptive, inflammatory, visceral, somatic, or neuropathic is transiting to chronic persisting pain, which is described as pain persisting longer than the healing time. And this healing time is very variable. It can be 3 to 6 months. So we need to try to be proactive in order to help blocking this transition. When you look at the literature, and this is a very interesting paper in 2018 in Pain, showing that professionals consistently tend to underestimate pain compared to what patients are telling us. And this is a more pronounced when we have more severe pain. So this is the reason for undertreatment and the gap of the pain treatment for postoperative pain. This is a very interesting German study in anesthesiology some years ago, gathering more than 70,000 patients. And the take-home message from this slide is that If you have major abdominal surgery, pain after that is not very important because we take care of these patients, major abdominal surgery, comorbidities for these patients. But when you look at these small surgeries, appendectomy, cholecystectomy, hemorrhoids, tonsils, which is the most important bulk of all surgeries, the pain after surgery is very severe. So we need to do something to take care of all these patients together. When we talk about chronification and chronic post-operative pain, the data is very striking because you have up to 60%, 50 to 60% of pain after 1 year after a coronary artery bypass surgery, amputation, thoracotomy, breast surgery. I'm going to give a quick example later. So why does it occur? Why this transition between acute to chronic? When you look at the initial insult after surgeon starting to his surgery, we know that there's a chemical soup governed by these prostaglandins that will sensitize all the primary receptive fibers. And these prostaglandins will be what we call in France the primum movens, the initial insult, and all these mediators will be responsible of this acute pain, which will lead later to chronic pain if not well tackled. It's not only nociceptive, it can be also neuropathic, acute, when the surgeon is not taking care of these nerves and not doing the nerve-sparing technology or techniques. Then you know that all these pain pathways, again, pain pathways, all these pain pathways are remodeled. There's a remodeling, there's creation of many other fibers like A-beta fibers, which will be responsible of this allodynia and hyperalgesia after surgery. And from the periphery, we move to the central compartment, and we know that all these prostaglandins will be crossing this blood-brain barrier. And this crossing is the most important factor that will lead to this chronification, because all these glial cells will be remodeled, will be modified with irreversible impact. And this is the most important point, irreversible. And we see these patients suffering 1 year, even 10 years after surgery, because of this central sensitization, because we did not do our job as proactive action. Are we in control of pathophysiology? We know that there are the peripheral role with all the tissue injury and liberation of all these mediators, activating all the nociceptors. And if the pain is not well tackled, if it's intense, if it's prolonged, then the central sensitization will start with upregulation of the nitric oxide synthetase, for example, neural and glial remodeling, and long-term potentiation. Where does the regional anesthesia play a role? We have a role in playing here, blocking this transition and controlling the neuroimmune reactions after surgery. So we have all the reasons to be convinced that regional anesthesia will be a very important factor to block this central sensitization and to block this chronification from acute to chronic. There are many risk factors for chronic post-surgical pain, preoperatively, intraoperatively, and post-operatively. And I focus on this perioperative. We don't talk only of post-operative pain. It's a perioperative management. Mainly the post-operative factor, we have the moderate to severe acute pain, one of the major risk factors for chronification. And we need to tackle pain as early as possible using this concept of multimodal analgesia. And Patrick was talking about the ERAS. Multimodal is well integrated within this ERAS programs. And of course, regional anesthesia is the major factor within this multimodal concept to treat and to prevent acute to chronic. And regional anesthesia, as I said, is one of the important part of this cocktail of the perioperative multimodal analgesia for our patients. There are many assessment scores and predictors regarding this transition from acute to chronic. One of them is, of course, pain before surgery at the site of surgery. This is a very important point. And the higher the score, the higher risk of having intense postoperative pain and high risk of chronification. So one of the take-home messages here is to be proactive again and not to do regional anesthesia after the surgery and do it before surgery in order to block all these neuroimmune reactions and hormones. And this is the first important take-home message. The other take-home message is that the type of surgery, we have 3 points here. So the higher points, the higher the risk. And thoracic surgery, we know that there's a big risk of having chronic pain after thoracic surgery. So I'm going to take one example of this with data supporting that. So this is an important data showing a paper, Chronic Post-Thoracotomy Pain. It was a retrospective study, and they looked at these patients, general anesthesia with or without epidural analgesia, and they looked them 2 years after surgery. So the incidence of chronic pain without epidural analgesia was 52%. The acute postoperative pain was very high, and severe postoperative pain was present when epidural was not possible. And they noticed also that the more the surgery is extensive, the more the risk of having chronic pain. Another paper comparing IVPCA with thoracic epidural analgesia, they looked at chronic pain after 6 months, and with epidural, they have only 12%, with PCA 23% of chronic pain at 6 months, including quality of life disturbance with sleep disturbance also on that. So there's some advantage in using the regional anesthesia in order to block this transition and to prevent chronic pain. This is another important message also from this paper, where they divided the group into 3 with IVPCA, preoperative and post-operative thoracic epidural, and only post-operative thoracic epidural. And you see here in yellow where they combined the epidural before and after. So they used the epidural during surgery, during this thoracotomy, and they noticed that at 6 months, 2 months, and 6 months, very significant reduction of this risk of chronification because they were very proactive and they showed efficacy of this thoracic epidural pre and post-operative. The role of regional anesthesia for prevention is essential throughout these pain pathways, starting from periphery at the transduction side where they block all these mediators, and at the level of the conduction where all these nerve blocking nerve by regional anesthesia will be an important point, an important step in order to block the central sensitization of the acute pain. Data has been published some years ago by a group of in the Gulf region here. I was glad to be part of it. We recommended some recommendation to help with the postoperative pain management. We had like 9 recommendations based on the level of evidence. And you can see here at the level of evidence A, where you have the multiple randomized controlled trials and meta-analysis, regional anesthesia here at number 6.6, regional blockade with local anesthetic should be considered as part of the multimodal approach for pain management. Very strong evidence for that. And the long-lasting perioperative analgesia should be employed in all patients to reduce the risk of persistent post-surgical pain. So we have strong data. It's not only imagination, something strong that is present with regional anesthesia helping for pain reduction and blocking the chronification of pain. I started with the pain pathways with René Descartes, showing on and off at that time, but nowadays this pain pathway and this concept has evolved, and you can see it's multifactorial, and you can look at the nociception, for example, here, where regional anesthesia has very important role. It's paramount to have regional anesthesia during surgery, before and after, to block this nociception and to block this peripheral sensitization, trying to avoid the central sensitization as early as possible in order to be, as I said, proactive. And with regional anesthesia, you block all these neuroimmune concept and neuroimmune liberation of this chemical soup peripherally and centrally regarding these pain pathways. It's not only that, we have other alternative methods that can help with that, but regional anesthesia, as you can see here, has a great role in blocking all these pain pathways regarding this passage between acute and chronic. So we need guidance, we need guidelines, and for this, regional anesthesia will be a good option. So guidance, some surgeons need sometimes guidance. Thank you for your attention.
Thank you very much for all to this excellent presentation. I want to tell you that there is no time for question, and if somebody want to send question, they will mail to the doctors. But I have here for Alain Delbos, why do angle block with 5 injection if I can do popliteal sciatic nerve block? With adductor canal, I put a tourniquet on the distal thigh.
Yes and yes. Just to say that the reply is very simple. Try to use ankle blocks and you will see that it's fully different than popliteal nerve blocks. For sure, with only one injection with popliteal nerve blocks, you obtain an impossibility to walk, a foot drop, and you cannot walk at all. So it's a real trouble. With ankle blocks, 2 hours after the surgery, you come back to your car walking. So this is the main difference, and during 24 hours, it's exactly the same. So first of all. Second thing, for adductor canal, of course, it's not a femoral block, and so you cannot support the tourniquet with an adductor canal. So it's only for analgesia, because you will organize with the adductor canal mainly an analgesia with the vastus medialis nerve and the saphenous nerve only.
Thank you very much, Dr. Delbos. Dr. Hisham Jabbour, do you have some questions?
Yes, thank you, May. Thank you all for your excellent presentations. So I want to combine distal block with business. Is performing more distal block could be more time consuming to do this regional anesthesia? What do you think, Patrick?
Oh, the question is for me.
Yes.
I thought it was for Alain.
Because Alain will do this, he will respond at the same time.
No, you are right. It is definitely more time consuming. And what you should know about this probably should be said by Alain, is that these distal blocks are more painful for the patient. So you need to sedate them a little bit before doing this multiple infiltration in the ankle area. Now, it is time consuming, but as I told you, if you have a block room, you anticipate all these patients. You know that distal blocks at the ankle, you will need maybe 25 minutes. So you ask your patients 30 minutes before or 1 hour before to the block room, and you have enough time to do all these distal blocks. If you do your block inside the operating room, then this can become an obstacle to distal blocks. Do you agree, Alain or Ammar?
Absolutely. This is I agree 100%. The block room is a must. You can use it. You can do it in the recovery room. You can have a specific block room, like in the American system or Canadian system. But the block room is a must. I agree.
Yeah, fully agree with block room, but you have to know that after, for example, ankle blocks for foot surgery, 5 minutes after the block, you can operate. Operate after 5 minutes after a popliteal block. You will see what will happen. You need half an hour to be sure that your block will be done. So more or less the same in operating room, in fact, for ankle blocks, for example. But I fully right that it takes a little bit more time when you are useful. But all in all, you have all interest in, particularly in forefoot surgery, is for distal blocks.
And you block the chronification of pain.
Also.
This is very important data on that.
Yeah, and a question to Ammar.
Yes.
What do you think about additives, about rebound pain?
Yeah, rebound pain is something important in the regional anesthesia domain. We need to be proactive and to prevent it, and we need to be, as I said, the perioperative management, not only the block itself. So we need to also educate patients about that. Tell the nurses that probably when the block will wear off, they need to have something before that. So the additives will give more time for the block to fade. So it's going to fade slowly. So it's going to be more easier to manage rather than having a block which completely wear off without any time to act. Okay. I use Clonidine. I don't know if you're still using Clonidine, but I use Clonidine for that. IV dexamethasone to help with that. So.
Thank you very much, but we don't have time. Dr. Noreddine, did you receive one question?
Yes. Let's thank all doctors for an enlightening and absolutely wonderful presentation. I have a question to Dr. Salti. If regional anesthesia may reduce the risk of chronic pain, what about neurologic nerve damage?
It's a completely different topic. Of course, nerve damage is one of the things that we always think when we do regional anesthesia. And with evolving of ultrasound and visible blocks with the tip of the needle visible, we know that we reduce a lot the nerve injuries. But I insisted on this nerve-sparing techniques with our surgeons. So acute neuropathic pain after surgery, something which exists. Our new generation of surgeons are more aware of that, but probably they need to think about it more in order to reduce this neuropathic pain after surgery. From our side, I think we're safe now with ultrasound, with all the education that we're doing all over the world. But from the surgeon side, they need to think about it. How do they approach the incision? How do they change their method from nerve sparing and muscle sparing for thoracotomies, for example? This is an important point to look at.
Thank you very much for everybody. We have to close.
Thank you, Mai.
Thank
Amazing.
you, Alain. Thank you, Ammar. I hope we will see you in August in Lebanon. Come to Lebanon and help Lebanese people. Bye, Hisham.
Pleasure.
Ciao.
Thank you, Hisham. Take care, guys.
Bye.
Thank you.
Bye.